time for a clinical journal club for this week in English. The image from the New England Journal involves a 32-year-old man who presented to an emergency department because he couldn't swallow properly. And what we see here is a view through an esophagoscope, upper esophagus. And since it's upper esophagus, we can forget about gastroesophageal reflux disease. We can scratch off Barrett's esophagus, and we're left with three additional possibilities: Crohn's disease, eosinophilic esophagitis, and Plummer Vinson syndrome. Plummer Vinson syndrome is a manifestation of iron deficiency anemia, and this patient is a little too pink for that. Crohn's disease should show a spotty distribution, but what we see here, and what's remarkable, is these ring structures. It almost looks as if we were glancing down the trachea. And indeed, this is called a trachealization of the esophagus, and it's characteristic for eosinophilic esophagitis. And that indeed was the correct answer. An endoscopic finding is esophageal rings or trachealization. And basically what happens here is a massive infiltration of eosinophils and T cells, which I presume is responsible for the formation of these rings. Reflux esophagitis, we would look at a view from the lower esophagus, a lot of inflammation because of reflux of material. That isn't the correct answer here. Crohn's disease should show a spotty distribution, granulomatous changes. Characteristic picture is here. The esophagus isn't commonly involved, but it's certainly not impossible. We would expect involvement elsewhere in the gastrointestinal tract. Barrett esophagitis, what we see here is the invasion of the lower esophagus and the replacement of squamous cell epithelial cells with columnar epithelium and also goblet cells. And this is basically a pre-malignant change and has to be intensively followed and treated. And this is eosinophilic esophagitis. Again, notice the formation of these rings. And if a biopsy is performed, you can see numerous eosinophils and round cell infiltrate. Presumably, this is a manifestation of some sort of a food allergy. I'm not enough of a gastroenterologist to be able to further comment on this disorder. And this is Plummer Vinson syndrome. This is a manifestation of iron deficiency anemia, and therefore the esophagus is pale. It looks atrophic. There's abnormal growth here and the production of membranes that can even result in obstruction. And the treatment is ferrosulfate and finding a bleeding source, presumably. Now, the first topic in the New England Journal involves omega-3 acid ester 90, which is also called Icosapent Ethyl. This is, in essence, we can view this as a product of fish oil research, where investigators are actively looking for components that might be responsible for the fish oil effect. Famous topic here at the MDC, efforts led by Wolfgang Schunk, and I would be interested in what he thinks about this paper. Icosapent ethyl is at least in part synthetically produced, and the idea is that this product might lower triglyceride levels and therefore have a favorable influence on cardiovascular disease. This is a large study where 8,000 people were randomized to treatment with Icosapent ethyl or placebo. And these patients had a cardiovascular risk. Their mean age is about 65. They have commonly have hypertension, they have type 2 diabetes, they're already treated for the most part with statins, so LDL cholesterol is not an issue here, and their triglyceride levels are elevated, but not massively elevated. And these patients were the ones that were randomized to Icosapent ethyl or placebo. And basically, here are the results. Again, the primary endpoint was a composite of cardiovascular death, non-fatal myocardial infarction, stroke, coronary revascularization, or unstable angina pectoris. And we see a positive result. Fairly modest number of events, but in any event, about 20% of the patients had an event, and the chances of an event occurring were less in the group that got Icosapent Ethyl compared to placebo. And since it's not that common to have positive results in these fish oil studies, I think this is a remarkable result. And we see that practically everyone benefited, all these subgroups shown here, with perhaps the exception of those that had relatively low levels of baseline LDL cholesterol, but that's not statistically significant anyway. And if we look at the composite secondary endpoints, which were expressed before the study was done, we see that secondary endpoints, the hazard ratios for cardiovascular death, non-fatal myocardial infarction, etc., were also reduced. And if we look at this more precisely as shown in this graphic, Icosapent Ethyl was better for everybody. So I think you might consider buying stock in this company that produces Icosapent Ethyl, but perhaps Volkswagen has a better idea. So this trial was named Reduce It, referring to the triglyceride levels. The effect on triglycerides was positive, but that isn't even the point. There were hard endpoints that were selected here, and the editorialist was indicated that baseline LDL cholesterol levels were already well controlled with the statin therapy, and the triglyceride levels were only relatively modestly elevated. So presumably there are other effects playing a role here. And exactly how Icosapent Ethyl works, we don't really know, but it worked. The next study is actually a composite of two studies where patients with cardiovascular risk and also risk from getting cancer because they're older were randomized to basically two treatments, a marine omega-3 fatty acid treatment, fish oil treatment, and they were additionally randomized to vitamin D or placebo. I'm not quite certain why one would select vitamin D in terms of preventing cardiovascular events or cancer, but that was done. Fish oil, I might imagine, at least for the cardiovascular issue. But in essence, the composite endpoint here involves coronary revascularization and death from cancer. And what we see here is lots of people were randomized, and they had cardiovascular risk, and a number of them have already been treated for cardiovascular disease with operations and stents, and primary tumors have also occurred in this relatively older collection of patients at risk for getting various tumors. And what we can see here is that not much happened. The real world is shown here. And if we expand the ordinates so that we might see something, we can see that there was absolutely no effect of these treatments. We'll first consider the fatty acids compared to placebo in terms of any major cardiovascular event or any cancer. So it looks like omega-3 fatty acids, just generic mixture, doesn't prevent cardiovascular events and doesn't prevent cancer. And we can look at various subgroups in this forest plot and reach a similar conclusion. So omega-3 fatty acids didn't help. So now, and sad editorials of looking into that. So now we can look at the vitamin D results. Now, basically, this is the same collection of patients randomized to these treatments: fish oil, placebo, vitamin D or placebo. This is a multifactorial study design, which is more efficient, and I think the study design is reasonable. Here we again look at the patients and what the primary endpoints were, the kinds of cancers they got. Cancer occurs in people that were older, and there were 24,000 people randomized here. And here again, here's the real world down here. Invasive cancer of any type, major cardiovascular events. Now we're comparing placebo to vitamin D. Nothing happened. So vitamin D doesn't prevent heart attacks or the risk from cancer either. I thought it was there for bone disease. So a lot of this material is sold, and a lot of studies have looked at older patients and have determined that they have low vitamin D levels. But I'm not really aware of any vitamin D therapy study aside from treating osteomalacia or rickets that have shown great benefits from swallowing vitamin D. So I think I'll discontinue mine. Thank you very much. Now in Germany, there's discussion about the interaction between vitamin D and vitamin K. And right off the bat, you wouldn't imagine any connection, but we have to remember what vitamin D really does. It is basically a coenzyme that enables a carboxylase to carboxylate glutamine residues in 4 clotting proteins to activate them and other proteins. I wouldn't think the clotting factors have anything to do with vitamin D, but the growth arrest specific gene 6 has something to do with bone disease because it's involved in the function of various receptor tyrosine kinases, and it's a vitamin K dependent protein. And osteocalcin is a vitamin K dependent protein. And the matrix GLA protein is also a vitamin K dependent protein. So we might imagine that in order to have vitamin D working properly, our vitamin K dependent proteins have to function. And there was a huge 72,000 proband epidemiological study that was published about now almost 20 years ago that showed that there's an interaction between vitamin K and vitamin D, and that's where that idea comes from. The next topic is CAR T cell therapy. And this is a very novel therapy. What we do in this case is harvest T cells from patients, then engineer these T cells with novel T cell receptors, instructing these T cells to please go out there and attack cancer cells. And we're aware that this therapy has been directed towards CD19-expressing cells, making this therapy perhaps a reasonable treatment for patients with B-cell lymphomas. And that's what was done here. This preparation has a difficult generic name, tizagene leucil. And basically what this refers to is T cells that have been engineered to go after CD19 expressing B cells. And these are patients with large B-cell lymphomas that have failed other therapies. And some of them have even had autologous stem cell transplantation. But as long as they've still got their own bone marrow and you can get T cells, then you could engineer the T cells to go after CD19. And that's what was done here. And best overall response rate, the 0 line is here. And this is not a randomized trial because all these patients had already failed other therapies. But what we see here is that the response rate is variable, but it looks pretty good for all patients, irrespective of age, gender, previous response to other treatments, etc. And the molecular subtypes of large B-cell lymphomas didn't seem to make much of a difference either. Now, the first thing that we can look at, in blue are the patients that responded very well indeed. But even the patients that didn't do that great, at the end of 18 months, almost half of them are still there. So presumably, since they have refractory B-cell lymphoma, they showed some degree of response. But other patients responded very well indeed. And the most common side effects to this CAR T-cell therapy, anemia, pyrexia, decreased neutrophils, diarrhea, all these things are tolerable. We might imagine that infections could be a problem. Those indeed occurred, but this didn't seem to be a major problem. And neurological events also were relatively confined. So this study suggests that this novel CAR T-cell therapy could be an option for patients with refractory B-cell lymphoma that have not responded to other treatments. Complicated review in the New England Journal, but I would encourage you to tackle it anyway, because this has to do with oligonucleotide treatments, a sort of a gene therapy, if you will. And these antisense treatments are directed at RNA. And this idea has been around for 25 years. But the problem with antisense treatments has been to make a backbone that is resistant to degradation, to make a structure that is incorporated into cells so that this specific therapy can be applied. And considerable advances have been made in this particular kind of treatment. And we're going to see more and more compounds that are directed oligonucleotides directed at treating diseases at the RNA level. So we'll have a look at some of these treatments which are being used for cancer, cytomegalovirus, Duchenne's muscular dystrophy, hypercholesterolemia, AIDS, etc., spinal muscular atrophy, and we've looked at some of these treatments already. There are 4 classes that are discussed here. Oligonucleotides to address changes in splice function, exon skipping treatments where a mutation occurs and we try to get around that mutation by skipping the entire exon so that we make a truncated protein that might still have some function. That's the strategy that's been applied for Duchenne's muscular dystrophy, which to my knowledge still is devoid of any useful treatments, including this one, incidentally. I haven't seen studies yet that this is convincingly effective. Spinal muscular atrophy we've talked about already, and this involves a mutation in the SMN1 gene, and the idea here is to get the latent SMN2 gene that we all have to wake and make a functional protein to substitute for SMN1. And then there are cleavage-based mechanisms for the destruction of mRNA that are also utilized, particularly addressing microRNAs and regulatory elements and things of this nature. So this is an example in this illustration here of exon skipping. There's even a drug, oligonucleotide, that's been developed in hopes that this helps patients with Duchenne's muscular dystrophy. And the administration here, the material is internalized inside the cell, and the idea is to hybridize a site on exon 51 that causes the spliceosome to skip exon 51. That results in a truncated protein, but perhaps the protein might have some function. That's the design here. Then exon switching, we've talked about this therapy already for spinal muscular atrophy, where the hope is that we can wake up the SMN2 gene to make mRNAs that are functional. What's the strategy here is to force the inclusion of exon 7 into this mRNA to make an effective mRNA that then would make the protein to avoid this disease. This treatment, as I recall in the paper that we reviewed from the New England Journal, is an intrathecal treatment, and it probably would have to be continued throughout the lifetime of the patient so that he makes this important protein. We've looked at Here's a strategy to deal with apolipoprotein B mRNA. This would be an LDL kind of treatment where the oligonucleotide would hybridize with the mRNA and to activate an RNase H, which recognizes this RNA DNA heteroduplex to cleave the ApoB mRNA. That's the hope here. We've looked at this next strategy also that involves PCSK9. This is an adapter protein that leads to degradation of the LDL receptor, and if we can suppress this adapter protein, then the LDL receptor would be continually expressed and we would have low LDL levels. So this is a hybridization strategy that is involved in this particular treatment. So here are a list of these things and how these oligonucleotides are made. And this review looks at this in substantial detail. There are interesting targets here that involve RISC and Argonaut enzymes that are involved in the production of microRNAs, regulatory components, which are also targets for this treatment. Review in the New England Journal, in addition to mRNA oligonucleotides, involves understanding the links amongst opioid use, overdose, and suicide. This tragic topic draws attention to the fact that deaths from opioids in the United States now exceed the deaths from diabetes. That is hard to believe. And if we look at these figures, age-adjusted rate per 100,000 Americans, if we look at deaths involving opioids, these have increased from 2.5 in 2000 to over 12.5 by 2016. So this is an immense problem that has to do with the prescription also for pain medicines, but that's not the topic of this review. And it's difficult to separate suicide deaths from opioids from unintentional deaths from people that just overdose by accident because they're junkies. You can figure it out for yourselves. And these separations are made, and there's effective gender and age in this kind of distribution. And you'll recall that Donald Trump expresses the views that the problem here is that all this heroin is being imported from Mexico, and so he said yesterday in his speech, and to justify the building of this wall, which is supposed to ameliorate this problem. But I think if you read this review, you might think that there are other factors that influence this sad state of affairs. Now, last week we looked at this patient with polyarteritis nodosa, and here are a couple of pictures. Here are his feet, and this diagnosis was eventually made by biopsy, and this patient responded to treatment. Differential diagnosis here, of course, is embolic disease from infected heart valves, and that possibility was also considered and ruled out. The next little report in the New England Journal involves deaths in Colorado attributed to kratom. I had never heard of this. Kratom is apparently a pflanzliches Heilmittel, which is derived from this plant, which is a favorite add-on for people that are involved in opioid abuse. And in this analysis from Colorado, one was able to establish that there are deaths from this material alone without the presence of conventional opioids. Here's the patient from last week that had erythrodermic psoriasis. And this little discussion that you can look at on your own discusses the differential diagnosis and how the authors reached the conclusion. This patient was HIV positive. He did well with antiretroviral therapy and triamcinolone, and his skin got much better. The patient in the New England Journal is a 71-year-old woman with a history of locoregional recurrent breast cancer. This breast cancer expressed the expected receptors, and she had been presumably adequately treated for breast cancer. but she shows up with severe shortness of breath, symptoms of heart failure, which was unexpected. I'm not quite certain if this problem could be diagnosed with a stethoscope alone. She had a holosystolic murmur suggesting mitral regurgitation, but on this echo examination, we see that she has a mass inside her right ventricle. And then as the differential diagnosis, what causes a cardiac tumor? Is this a primary tumor? Is this a metastasis from her breast cancer? Or is this perhaps she was treated with a PARP inhibitor that might promote the development of other kinds of cancers? So this possibility here is discussed. MRI shows this big tumor, and how to get at this thing. Can we biopsy this tumor with a catheter, or would another intervention be necessary? So that's the discussion here. And eventually, in order to provide a treatment, a surgical approach was elected since a catheter was not effective in making the diagnosis. So this patient was operated upon. This tumor was removed from her right ventricle. A pericardial patch was made to fix all this up. And if we look at this tumor, it's a sarcoma. And so this is a second cancer. Whether or not this is related to any of her treatments is unknown, basically. But this tumor then, this was an aggressive sarcoma. It recurred, and this poor patient then died. Question in the New England Journal, the question of the week is you're confronted with a 70-year-old patient that has decreased renal function. Serum creatinine is 1.9. So at her age, she's labeled as having stage 4 chronic renal disease. And she has bone lesions from multiple myeloma, which should be treated with pomidronate. But then is the question, what are the guidelines in terms of decreased renal function and administering pomidronate? We've already learned that vitamin D isn't worth much. Cinacalcet isn't going to fix the problem. Calcitonin won't help either. But denosumab is an antibody that's directed against NF-kappa B ligand, which plays a role in osteoclastic activity. And the discussants here argue that her renal function is too bad to warrant treatment with pomidronate, which we would otherwise apply. And so denosumab is the correct answer. This is the antibody against a nuclear factor kappa B ligand called rankle. Now, in the Lancet, the first topic is it's a meta-analysis on the use of SGLT2 inhibitors, which, in my view, are a dramatically successful treatment for patients with type 2 diabetes, perhaps even as good as bypass surgery. SGLT2, to remind you, is present in the proximal nephron, where the transporter pumps in sodium combined with glucose. So if we inhibit SGLT2, these people should have glycosuria, and they should also lose some sodium, which they probably do. Now, the reason that this is so effective, in my view, is if the patients get hypoglycemic, they filter less glucose, and then the drug is less effective, so that you have a built-in safety component here. Now, having glucose in the urine might make one more prone to candida infections and things of this nature, but actually this treatment has been amazingly successful. And this is a meta-analysis. And here's the abstract of this paper, which you read on your own. And what annoyed me terribly is that Elsevier is in a clinch with my medical institution, so I couldn't access this paper without paying 30 euros. But since I've already read the primary papers, I knew the answer. And SGLT2 inhibitors have a modest effect on large vessel cardiovascular events, although there is an effect. but they look very good, particularly for avoiding hospitalizations from heart failure and the progression of renal disease. And these effects are major. Sorry I couldn't pull the paper out for you. The next paper in the Lancet I did successfully access, and it involves an oral pharynx carcinoma, which we now know is associated with papillomavirus. So the vaccine against type 16 papillomavirus should be a good prophylaxis against this tumor, and actually this vaccine should be not only given to young women, but also be given to young men, but that's not the topic here. So human papillomavirus is a risk factor for the development of pharynx carcinoma. And the treatment for pharynx carcinoma is platinum. And platinum has a lot of toxicity, and in this study, the idea was that perhaps a blocker of the epidermal growth factor receptor would be as good as platinum. So this is in a comparison between cetuximab against a platinum-based treatment in patients with a papillomavirus-associated oropharyngeal carcinoma. Primary outcome, toxicity events, intention to treat, etc. And what we see here is that actually the overall survival of patients treated with oropharyngeal carcinoma associated with papillomavirus is really pretty good. So that at 2 years, there's hardly anybody dead. But the epidermal growth factor receptor treatment was not as good as platinum, although it had somewhat less side effects. And that's discussed in this table, risk factor for events associated with these things. But basically, this study was negative and suggested that the platinum therapy should remain the gold standard for the treatment of this tumor compared to cetuximab. The next trial in the Lancet I was also able to access, and it involves patients with cardiomyopathy who are treated for heart failure, and they're treated with diuretics, ACE inhibitors, and blockers of the mineralocorticoid receptor, spironolactone, and beta blockers. Some of these patients get better, much better. And then there's the idea perhaps some of these patients can have their medications stopped because perhaps they're cured. So in this study, patients that had gotten better from cardiomyopathy with these heart failure treatments were randomized to discontinuing their medicines in a stepwise fashion or just leaving them on their drugs. Pretty complicated study. So here are the patients and their blood pressures and whether or not they had left bundle branch block, and their NT-proBNP values and this sort of stuff was the same in both groups. So both groups had gotten better. But what we see here is that the patients that had their treatment withdrawal, half of them relapsed, whereas the patients whose medications were just continued to do well. And there's a breakdown here in terms of their dimensions and proBNP levels, etc. But there was no criterion which allowed one to predict who was going to stay good or who was going to get worse once the treatment is withdrawn. And here are the drugs that were withdrawn and the various strategies that were applied here. So basically, we can accept the fact that these patients with cardiomyopathy who got better on treatment, which is desirable, probably ought to just stay on the treatment, particularly if they tolerate it. So I couldn't access the review in the Lancet, but your heart probably won't break because I got a better review out of JAMA. And the review in JAMA is on in-flight medical emergencies. Now, even at my age, it's disconcerting when you're sitting inside the Lufthansa aircraft and suddenly somebody says over the loudspeaker, is there a physician on board? And so this is a review of what doctors are confronted with. And about a third of episodes that result in doctors being called on aircraft have something to do with dizzy spells or pre-syncope or whatever you want to call it. GI complaints are fairly common, shortness of breath, cardiovascular disease, and the necessity to make a decision to divert the aircraft is actually uncommon. One of the things that's changed dramatically in the last 15 years is what the aircraft have on board. In the United States, the aircraft have to have a cardiac defibrillator. In Europe, that's not mandated as yet. But in the routine medical kits, all sorts of things in there. Some of them even useful. Epinephrine is a good idea. Lidocaine, maybe. Nitroglycerin, less so. Atropine sometimes is pretty helpful. And all these tools that are available, and there's material now to start an IV inside an aircraft. I've been in Germany for 30 years and I've started no IVs in 30 years, and I would be rather reluctant to do this in the narrow aisle of a Boeing 737 in the middle of the night on some person with a body mass index of 35. One of the problems. Now, additional contents in some of these kits are a whole bunch of largely irrelevant material. Am I going to give anybody digoxin on an airplane? So all that's reviewed here. And also radio contact with the ground and getting advice, not a bad idea. Is there a risk that you're going to get sued? Trivial. Should you jump to help somebody if you've already had 4 drinks in first class? Probably not. These things have to be considered. Then aircraft diversion. The costs of this range from $20,000 to $725,000. And sometimes airline pilots are not very keen on doing this. And then there's some advice on near syncope and gastrointestinal and stroke-like symptoms and how to make the decision whether or not an aircraft really ought to be diverted. So this is a good review to look at unless you're confined to ships and cars. So those are the considerations. I guess the best idea is to prevent medical events on aircraft. And this would require the patients also being sensible and being sober and taking care of their medical problems before they get on board. The last patient that we have is this young person from Syria. He's 5 years old and he's coughing. So he has this chest x-ray and it's remarkable. His whole right upper lobe is diseased. There's marked pleural thickening here. There's partial collapse. Not quite sure whether this is lung parenchyma or not. And he's got this huge abscess form structure here. So he gets this CT and we can look at this in more detail. And here's even this thin membrane in this cavity. And the discussants, is this tuberculosis? I don't think so. Is this an abscess with Staphylococcus aureus? Probably not, because this patient isn't acutely ill. Could this be Echinococcus granulosus? I like that idea. This patient didn't have eosinophilia, but then he was treated and then the eosinophils occurred. So the conclusion here is that this is a rupture of a Echinococcus granulosus cyst. And I think this is a probably good reason to operate on him to take this dog tapeworm out. Thank you very much for your attention. And if you can deal with this, we can continue this discussion in German, but you'll have to wait 20 minutes.
Ja, was denn sonst? Ja, also, was heißt mit, er spricht auch regionalisch, ne?